Now, I would like for us to look at one of the surgical emergencies, that is acute appendicitis. So in this lecture, we will look at the complications of appendicitis. We will look at the function of the appendix, take a look at the anatomy and its anatomical positions in the peritoneal cavity, the causes of appendicitis, as well as the pathophysiology of appendicitis, the types, the stages, the special forms, and some of the clinical manifestations of appendicitis, as well as its management. Now, appendicitis is an acute inflammation. If it's an acute process, that means it's occurring within a few hours or a few days, leading to the destruction of its walls. Destructions of the walls of the appendix, the perforation of its walls, leading to a very severe case of peritonitis. That is due to the rupture and release of the contents of the appendix into the peritoneal cavity. Now, this is the most common cause of an acute severe abdominal pain with a frequency of occurrence amongst mostly 20 to 30 years old. Now, this is because in children, the appendix, the lumen rather of the appendix, is usually wide, and this lessens the chances of obstruction. While in old people, the lumen of the appendix is mostly obliterated. Now, the appendix was initially thought to be a vestigial organ. Vestigial organ with no pronounced function, because patients who had previously undergone appendectomy did not show any complications or problems with digestion thereafter. Now, the appendix is a small pouch like tube-shaped structure that we are going to find attached to the tip of the cecum. That is this part, the beginning of the colon or the large intestine. And it typically drains its mucus and secretions together with the normal intestinal flora back into the cecum. Now, the primary role of the appendix is its participation in immunity and gut bacteria regulation. The appendix is also rich with lymphatic vessels, the B and the T cells that help regulate pathogens, that help regulate pathogens. It also acts as a reservoir for gut bacteria. It can then replenish the microflora, that is the normal microflora, following a gastrointestinal illness. This is why it is mostly referred to as the abdominal tonsils, because of its ability to protect abdominal tonsils, because of its ability to protect the intestines against, or the abdomen rather, against pathogenic microorganisms. Now, the appendix is positioned at the confluence, or rather where these three muscles meet, the tinea coli. These are the muscles that run along the longitudinal axis of the colon. Now, the appendix is joined to the terminal ileum. I want us to get a closer look at the structure right here, this yellowish structure called the mesoappendix, or rather the appendiceal mesentery. Appendiceal mesentery, which is the fourth abdominal mesentery. Now, let us get a quick reminder of the mesenteries that we have in the abdominal cavity. Firstly, we have the mesentery proper. I'll quickly write them here. Mesentery proper, which suspends the jejunum and ileum from the posterior abdominal wall. We have also the transverse megacolon, which connects the transverse colon to the posterior abdominal wall. We have the sigmoid megacolon, which connects the sigmoid colon to the pelvic wall. And what's the fourth one? The appendiceal mesentery. So, which is primary role is to suspend the appendix. You can also call it the mesoappendix. Now, branching off more closely into the mesoappendix, it contains the appendiceal artery, which branches off from the ileocolic artery. Now, this is of surgical importance since it has to be dissected. Appendiceal artery. It is of clinical importance because it has to be dissected in order to remove the appendix. It is also very crucial to know the variation of the mesoappendix and the appendiceal artery from person to person to avoid complications during surgery, because some people do have a mesoappendix coming all the way down to the tip of the appendix. Some people have the mesoappendix covering and coming over at least the half of the appendix. Now, going back to the examination of the abdomen, you will notice that the abdomen is most tender at a point 1/3 from the anterior iliac spine to the umbilicus. Now, let's zoom in. If we are to draw a point from the anterior iliac spine and another point at the umbilicus and join them, divide them into 3 equal parts. Now we're going to have this point. The McBurney's point, which is the most tender point in the abdominal cavity. Now, why are we talking about this? It is important because in this case specifically because it is where the base of the appendix lies. Now it is important to observe the reaction of the patient, especially when palpating around this area if appendicitis is one of the suspects. Now let's take a close look at the anatomical positioning of the appendix in the abdominal cavity. This is not the best picture, but it will help us have an idea of the different positions in which we could find the appendix in the peritoneal cavity. We have, assuming that this black line here behind it, this is the posterior, and this side is the anterior. Now we're going to have the first anatomical position being this is the retrocecal. We're going to have the paracecal, and then we are going to have the one directly beneath subcecal. Sub means under, yeah, subcecal, and then the one pointing towards the pelvic inlet, pelvic, and we are going to have this one subiliac. You find it directly under the ilium, and we are going to have post iliac because it is running post iliac, running behind the ilium, post iliac. And then here we are going to have the pre-iliac. Now the most common position here is the retrocecal. This is what you would find in most patients, followed by the pelvic. Now let's move on to take a closer look at the causes of appendicitis. But I want us to first understand that all the following causes that we would explain and look at are, or rather, they all lead to obstruction, which is the main step in the pathophysiology of appendicitis. Now, obstruction could happen due to, firstly, a fecal leaf. Now, a fecal leaf is a solidified fecal material, especially if it's situated at the entrance that is at the base of the appendix. I'm talking about right here. So this is a layer of the buildup of calcium salts and fecal debris around the fecal material that is already within the appendix. Solidified fecal material. It could be attached to also some, calcium salts can also attach to that, and some fecal debris. And then obstruction could also be due to parasites. Could be due to parasites. These are like pinworms, schistosomes, and even it could be due to inflammatory bowel diseases. Now, looking more into the pathophysiology of appendicitis, we would have to understand that the obstruction that occurs, due to these aforementioned factors that we already talked about, fecal leaf, hyperplasia, tumors, and traumas, and etc. Now, these obstructions, when they occur, more especially at the base of the appendix, that means that now the appendix can no longer empty out its contents back into the cecum. They continue to accumulate. Accumulation of appendiceal contents. Now remember, these are microorganisms. It could be pus collected in there, and also some of the fecal matter. It continues to accumulate and builds up. At the same time, secretions continues also. That means the contents of the appendix or luminal contents continue to increase because there is no drainage. It can no longer drain back into the cecum. Now, this is a very good environment for microorganisms within to proliferate, and they begin to multiply. Proliferate. Now, this elevated luminal pressure now begins to hinder capillary perfusion. Now, this is how it happens. Now, elevated luminal pressure begins, it starts off by stasis in the veins and pressing onto lymphatic vessels, congestion. Now, as this happens, as well as a heightened luminal pressure within the appendix, the arteries and capillaries supplying oxygenated blood to the appendix are going to be compressed. Now, compression of the arteries, now this is what will lead to decreased perfusion and supply. Decreased perfusion and supply of oxygen, nutrients, is what begins tissue ischemia. Now, the malfunctions in the energy production in the mitochondria begin. This is what compromises the integrity of the membranes. It starts off in the mucosal wall being compromised. Now, understand that we have the mucosal wall, we have the submucosa here, we have the muscular layer, we also have the serosa. Now, if the mucosal wall is getting compromised, that means now the contents, the original contents of the appendix, the microorganisms, the fecal matter, and secretions are now able to penetrate through the wall of the appendix. Now, when they reach the submucosa or penetrate the submucosa, this is what starts off some of the signs that patients tend to report. Now, this is due to the fact that the submucosa has got nerve endings, and all the vascular beds supplies are located in the submucosa. Now, transluminal inflammation ultimately leads to, remember that this is a vicious cycle. Continued and heightened inflammation, that means more congestions of the veins and lymphatic vessels, and the pressure also continues to increase. Compression of the artery, ischemia heightens as well. Now, this ultimately leads to infarction and perforation of the appendiceal wall. Now, this is what leads to the release of the contents into the peritoneal cavity. Now, types of appendicitis. Now, having understood how it all happens, appendicitis could be acute and chronic. Acute, as the name implies, it develops very fast. Usually in a span of several days or hours. And it is very easy to detect, and it requires prompt medical treatment. That is usually surgery. Both could be open or laparoscopic. Acute appendicitis occurs also due to there has to be complete obstruction of the appendix. complete obstruction of the appendix, increased luminal pressure, congestions in the veins, compression of the arteries, reduced perfusion, also ischemia, and transluminal inflammation, ultimately infarction and perforation. This is how it happens. And appendicitis could also be chronic. This is an inflammation that can last for a very long time. This is rare, and it means that the lumen is partially occurs for a very long time. And it means that the lumen is partially obstructed. Now, this means that the inflammation worsens over time, and in the same manner, it causes the internal pressure to build up. Now, let's look at some of the stages of appendicitis. We have the catarrhal stages. It has 4 sequential stages. First being the catarrhal stages or early appendicitis. Now, in this one, the luminal blockage is the main pathogenic event. This is what sets off the inflammatory process, and appendiceal wall perfusion diminishes as the intraluminal pressure rises because of arterial insufficiency. Now this leads to ischemia of the mucosal layer. Now in this one, the reason why it's called early appendicitis is because only the inner mucosal layer at this point is being, the barrier is being compromised, is being affected rather. Now it has not yet spread across the layers of the appendix. We have suppurative, that is transmural. Transmural, that means it involves more than one layer. Now this is when the microorganisms penetrate the luminal wall and cause the transmural inflammation. Now at this point also inflammation could be seen, or rather it also affects the periappendicitis. It's also called periappendicitis because it affects also the structures that surround the appendix. So this one, it affects multiple layers and also could penetrate even into the surrounding structures. Now we have gangrenous. Now in this one, there is thrombosis that could happen due to, remember, there is stasis, right, and congestion. That means the viscosity of the blood in the veins is high. Now this venous congestion could also result in the formation of thrombs, and these thrombs could thoroughly obliterate the blood vessel and completely cutting off the blood supply to the appendix. Now in this one, the whole layer is involved and necrosis begins. Now the last one, perforated or complicated appendicitis. Now this is when the patient with the gangrenous appendicitis does not undergo surgical intervention. This leads to appendiceal infarction and perforation, and therefore peritonitis. Peritonitis. Now, necrosis means cell death. Cell death, that means the integrity and the barrier and the wall of the appendix is damaged, and therefore now the contents, microorganisms, could now pass over and get to be released into the peritoneal cavity. Now let's look at some of the clinical signs of or clinical manifestations of acute appendicitis. Now the first one is going to be abdominal pain. Abdominal pain. Now it is worth noting that in the early stages, the pain is going to be felt as colicky. Colicky because as we talked and discussed about a periappendicitis affecting other nearby structures in suppurative appendicitis, the first structure to be affected also is going to be including the visceral layer. That is the layer that surrounds the organ. Now we need to understand that this is innervated by autonomic nervous fibers. That means that the pain is going to be dull, the pain is going to be colicky, and because the autonomic nervous fibers, they have low nociceptors, and they have also got the slow C type of fibers. So let's describe the pain here. At first, the pain is going to be colicky, the pain is going to be dull, and the pain is going to be localized around the umbilicus. Because also autonomic nervous fibers are not localized, so that is why the pain is first felt, which is of key clinical importance, first felt around the umbilicus, and then we'll talk about what happens later. Now, when the inflammation reaches the peritoneal, this is the visceral. When it reaches the parietal layer, now the pain is going to be more severe and intense. It's going to be sharp. And it's going to be localized on the right lower quadrant because the parietal layer, because the parietal layer is innervated by the somatic nerves. So these have got a lot of free nerve endings. It has got also a lot of mechanoreceptors, and it has the A delta fibers. Now, what we know about that is that they are fast in transmission, and also that's why the pain is felt as a very sharp, acute pain. So this is where we're going to experience what is called a migration of pain, because the somatic nerves are more localized. Now, some of the signs that are going to be observed from the patient include, let's first talk about the obturator sign. Now, in this one, the patient is going to be asked to lie on their left side, and then there would be a flexion of the right knee, and the moment it is then rotated internally, there is going to be a pain that is going to be felt around the right left quadrant. So this is the pain on passive internal rotation of hip when the right knee is flexed. Now we also have the SWA sign. This is when now also the patient is going to be asked to lie on their left side while the right thigh is going to be flexed backwards. Pain felt, SWA sign, pain felt. While the right thigh is flexed backwards. Remember that the patient is then lying on their left side. This is so because the appendix is lying on some muscles. Then remember we talked about the peri-appendicitis, inflammation of these muscles as well. Now the movement is what causes the pain to be felt upon performing all these. Now let's look lastly at the Rovsing sign. Now this is a pain that is going to be felt on the right lower quadrant while pressing or palpating the left lower quadrant. So I'm going to take it all the way down here. So this is pain felt on the right lower quadrant while pressing the left lower quadrant. Now, the management of acute appendicitis. This is an emergency. Acute appendicitis is an emergency that's usually mostly managed by an emergency surgery. That is appendectomy, that the complete removal of the appendix. Now, there is a special form or the special case, the special form of appendicitis called except plastron appendicitis. Now in this one, this is whereby there is a complete covering, or rather when the omentum and intestines wall up the pus as well as the ruptured appendix. Now this is usually treated conservatively with intervals, conservatively plus interval partial appendectomy. And its complete removal after a period of 6 months, considering the condition of the patient. This is so because, or this is done in order to avoid opening up an area of serious and severe inflammation. Now, thank you so much for watching. Please be sure to comment down questions and comments. See you on the next video.